Uh, Hello, hello guys. Sorry. Good morning, everyone. Um, my topic is approach to intracranial cyst. So, a previous year question from this topic is cystic lesion in infratemporal region, and twice question was asked on epidermoid cyst. So my topic is continuation of our brain tumor series only. Like we had finished about supratentorial, infratemporal lesions. So next is intracranial cyst, which is per se very important DDs for when we see many cystic lesion in brain. I have included only non-infectious causes because again my next topic is CNS infection, in which I will be including neurocystic sarcosis, tuberculoma, all the infectious cysts. So we have to remember that first we have to divide intracranial cyst into two. That is, we have to ask if it's extraaxial or intraaxial. If it is extraaxial, we divide it again into two, the midline cyst and off midline. In midline, based on location, we are having pineal cyst, which originates from pineal gland, cellular cyst, that is Radke cleft cyst, dermoid, which is again midline, fat containing CT hypodense. I'll be just telling few buzzwords, so later on it will be easy to correlate. Coming to off midline, we are having two, that is arachnoid cyst and epidermoid. Here, location we have to remember, arachnoid is most commonly seen in middle cranial fossa followed by CP angle. But per se, epidermoid is more common in CP angle. Coming to next, intraaxial. In intraaxial, we divide again into two if it's parenchymal origin or in the ventricle. In parenchymal, first we are having most common perivascular spaces cyst, that is Virchow-Robin space cyst, that is most commonly seen around the basal ganglion or subcortical white matter. Next is hippocampal sulcus remnant cyst, which is again identified on basis of its location. It is medial to the temporal horn of lateral ventricle. Next, most important cyst are porencephalic cyst and neuroglial cyst. So, porencephalic cyst is the one which will be communicating with a ventricle, and neuroglial will be having its own epithelial lining and it will not be communicating with ventricle. So, this is how we differentiate porencephalic cyst from neuroglial cyst. But there is one more important DD for porencephalic cyst, which is again a very important spotter, that is schizencephaly. So, which type of schizencephaly? It is open lip schizencephaly, which is communicating with the ventricle. Now, how to differentiate between schizencephaly and porencephalic cyst? Porencephalic cyst will be lined by white matter, whereas in case of schizencephaly, it will be lined by dysplastic gray matter. Here, it will be gliotic white matter. So, that is how we differentiate between two. Coming to intraventricular, most common is choroid plex cyst. This we see in antenatal ultrasound also. So in adults, we call as choroid plex xanthogranuloma. Next DD is ependymal cyst, and the most important one based on location, that is foramen of Monro, we are having colloid cyst. So this is difference between extraaxial, intraaxial, which we studied in previous class. So I'll skip that slide. Okay, now coming to the first cyst, this is the most common cyst. Here we can see in the first image, it is T2 hyperintense lesion, which is suppressed on flare. That is, it follows CSF signal intensity. And on T1 post contrast, it does not enhance because it is a cyst. Cysts don't enhance. And here we can see that it is having a thin covering, thin, it's lined by thin meninges, and it is pushing the adjacent bone, just thus suggesting that it is extraaxial. The main dictum here is it follows CSF. So we are having a extraaxial lesion following CSF, having mass effect on adjacent structure and also causing the bony remodeling. Here again, in the second case, we are having the lesion which follows CSF suppressed on flare, on post contrast does not enhance, has a mass effect on adjacent structure, and on diffusion weighted imaging, it is not showing diffusion restriction. So this is classical case of arachnoid cyst, which is most commonly seen in middle cranial fossa. As I told, most extra axial mass effect, scallop margin, skull remodeling is seen, follows signal intensity, doesn't show diffusion restriction. Then middle cranial fossa is most common than CP angle. Coming to next case, which is again, here we can see well-defined cystic lesion, which is hyperon T2. When we see this, it looks bit expansile and causing hydrocephalus. So it is causing hydrocephalus, but the twist is on flare. We can see some lesion. It is not. It looks like it is not getting suppressed on flare. We have studied that arachnoid should be suppressed on flare. Since it is located here, it will cause the obstruction in CSF flow, because of which there is the CSF flow related artifact. So when for this, how to see if it is epidermoid or arachnoid cyst, because epidermoid also is not suppressed on flare. So for this we do diffusion restriction. Epidermoid will show diffusion restriction. Another way to differentiate that if it is arachnoid cyst or epidermoid cyst is by doing CT cysternography. Here we can see the filling of the contrast in ventricle, whereas it's not opacifying the cyst, means that cyst is not communicating with the ventricle. So this is again our arachnoid cyst. Okay. So this is suprasellar arachnoid cyst causing upstream hydrocephalus at the level of third ventricle. Lesion is expansile, CSF flow artifact, CT cysternography, no enhancement and no communication. Now again, we are having two lesions. This is again the last type of our arachnoid cyst only. We can see a well-defined extraaxial lesion. It is located in the posterior coronal fossa. It is having mass effect on the adjacent structure. T2 hyperintense, suppressed on flare, doesn't show diffusion restriction. Again, we have to remember that we have in congenital anomalies, we'll study that different DDs for posterior cranial fossa lesion. We are having Dandy-Walker malformation, Blake-Pau cyst, megacisterna magna, but this will not show mass effect, and arachnoid will show the mass effect. That's how we differentiate it. And coming to next one, again here we can see at the level region of CP angle, T2 hyperintense, T1 hypo, flare suppressed, doesn't show diffusion restriction. Though in CP angle, most common is epidermoid. This is a case of CP angle arachnoid cyst. Coming to next cyst. So this is my hint, like I have asked question in the end. So here we can see the spindle shaped cyst. Again, it looks like arachnoid cyst only, but the location is different. It is T1 hypo. On T2, it is showing hyper intense signal. On flare, it is suppressed, but the classic is the location. That is, it is located where there is meningeal infolding between thalamus and the fornix. So if we see any cyst in this location, we have to think of choroid fissure cyst. That is most common. So this here will be the choroid fissure, and the cyst will be pushing the choroid plexus. So it is T1 spindle shaped lesion near choroid fissure, infolding of meninges between thalamus and fornix. Coming to next most important cyst. Here on T1 weighted image, it follows signal in CSF signal intensity, but here we can see that it is little bit dirty. And on T2, and oh, sorry, this is T2. Sorry, in T2, we can see that it follows the CSF and it is having little dirty signal intensity. When we are doing flare, it is not getting suppressed. On flare, we can see a heterogeneous lobulated lesion, which is insinuating the adjacent neurovascular structure. On diffusion restriction, it is showing nice diffusion restriction. So as I told, this is case of epidermoid cyst, and we have to remember that it shows diffusion restriction because it is made up of the cholesterol or keratin. As I told, collection of epithelium with desquamated keratin and cholesterol. It is producing the dirty CSF. In case on T2, it is heterogeneous. Flare may it is not suppressed DWI. It shows diffusion restriction. Non-enhancing lobulated lesion. Most common location is CP angle. Here we have to remember one more important DD, that is white epidermoid. White epidermoid is having so much keratin that even on T1 it will be hyper, but epidermoid will be hypo on T1. So whenever we are talking about T1 hyperintense lesion, one more DD will come is fat. So that is dermoid. So now again in this axial image, sagittal image, T1 weighted, we can see a well-defined T1 weighted hyperintense lesion, but it is not producing much mass effect. In case of flare, it is not getting completely suppressed, but it is showing diffusion restriction, thus differentiating it from our dermoid. Dermoid will be having even calcification and uh, other, it will be involving other germ layer. So, uh, just summarizing CP angle mass, most common if we are involving the tumor also, it is vestibular schwannoma. That is 75%, followed by meningioma 10%, rest is epidermoid, rest are rare. Then if one more way to differentiate epidermoid dermoid is usually midline lesion. So the take home point is, unlike an arachnoid cyst, they are bright on flare. So this is I'm again telling that epidermoid cyst does not completely get suppressed on flare, and they will show diffusion restriction. So coming to the next cyst, which is the important DD for our epidermoid, is dermoid cyst. So I have taken each cyst like which will be the most common DD. So that will be next case. I have kept it like that. So now, like I told, for most important DD for epidermoid is dermoid. So here we can see a heterogeneous. This is all images in my slides are taken again from Osborne and Crack the Core. So this is midline cyst, which is very heterogeneous, and we can also see in the ventricle it is showing fat fluid level, and in our subarachnoid spaces they are flat globules. In case of T1 weighted image, we can see a well defined T1 hyperintense lesion in the midline. In case of CT, it is hypodense, and post contrast, it is not showing any enhancement but located in the midline. So this is classic case of dermoid. Desquamated skin with hair follicle and sebaceous cyst, as we can see in this image. Typically midline, well defined, high signal intensity of fat, and if there is calcification and all, it will be seen as flow void. And we can even use fat sat sequence to see confirm that it is dermoid. It will be suppressed in case of fat sat sequence. There will be chemical shift artifact. Summarizing dermoid cyst, it is 4 times less common than our epidermoid. Epidermoid is most common. It is seen in kids, young adults, usually midline, contain lipoid material and hypodense on CT, very bright on T1, associated with neurofibromatosis too. Take home messages, they are usually midline, and the most common location for dermoid is usually suprasellar cistern, followed by posterior fossa. Now, next case, here we can see again well-defined lesion, T1 hyperintense lesion located in the midline in the paramedian region. And in next, we can see that it is showing hyperintensity in the sylvian fissure. This is the sagittal image where we can see hyperintensity in the sylvian fissure. And on flare, it is not getting suppressed. It is hyperintense. And when we do SWI, it is showing the blooming. So this is nothing but the case of dermoid, which was ruptured. As I have shown in the first image, if the dermoid gets ruptured, we can see fat globules in the cisterns, in subarachnoid space, sorry. So T1 hyperintense lesion in midline, fat lobules in the sylvian fissure, loss of signal on SWI. We have to remember that usually tumor or ruptured dermoid, clinically it is very difficult to differentiate because they will present with history of headache and seizures. So the main important diagnosing feature is the presence of the fat droplets. So coming to next cyst, um, this is having classical location that is in the prepontine region. We can see ovoid shape, well-defined cyst, and it is hyperintense on T1, hyperintense on flare, and post contrast it is enhancement. Till now, whatever cyst we were studying, we studied that it is hypo on T1 and flare it is getting suppressed if it is CSF signal intensity. But this is the one which is hyper on almost all the sequence. So this is a case of neuroenteric cyst. It is ovoid in shape. By its location only, we'll identify it most commonly, and it doesn't show diffusion restriction. And most common degree for this is acordosis physaeliform, but acordosis physaeliform will be having stalk with the clivus. That is how we will differentiate it. Coming to our next cyst, again based on the location here in first CT image, we can see well-defined hypodense lesion which is having the curvilinear calcification, and it is hyper on T2. Flare it is not suppressed. In case of post-contrast, it is not enhancing, located in the pineal region. So this is classical case of pineal cyst. Most important DD for this will be pineal cytoma, which is grade 1 tumor, and we can't differentiate between two, and we need not differentiate also because anyways we'll do follow up for both of it. So this is just summarizing all the pineal gland tumor. In case of germinoma, the classification will be engulfed or central. In case of blastoma and cytoma, it will be periphery. Again, we differentiate it based on age also. And in case of pineal cyst, it is mostly cystic. Coming to next cyst. So here we can see the cystic like lesion next to a mass. So this is nothing but tumor associated cyst, and this is classically seen in case of extraaxial tumors which will be compressing the adjacent CSF. So there will be like pooling of the CSF. These are not true cysts. They are not lined by lined by epithelium. It is just formed because of the mass effect of the extraaxial tumor. So first case, this is our meningioma, and it is we can see well-defined extraaxial tumor with vascular cleft. So it is compressing the brain, and the CSF gets adjacent brain and sorry adjacent parenchyma, and CSF gets trapped. Second case is of our vestibular schwannoma. Here we can see the fluid level, blood fluid level, and a big marginated cyst, which is again entrapped CSF itself. Here, in case of pituitary macroadenoma, which is having cellular extension, here we can see the blood fluid level caused because of the mass effect of the tumor. So, cystic looking collection near tumor, CSF collection or pool, compression of extraxial tumor. So, tumor associated cyst. Coming to next important spotter, that is, as I told in the beginning, these are the cystic spaces which are located mainly over the basal ganglion or subcortical white matter. The main thing is it is mainly located over the arteries which supply. For example, this is the lenticular striate artery. So these are the cystic lesion around it. It follows CSF signal intensity. On T2 weighted image, it is hyper. In case of flare, it is suppressed. So here we can see the cyst around the anterior commissure. And this is again the spotter image in elderly. If this is become more prominent, we call this as cribriform state or etet cribble. So this appearance is called as etet cribble or cribriform state. So again, as I told, it follows CSF intensity, most common in inferior basal ganglion. It will be accompanying the artery, penetrating artery, in this case, lenticular striate artery. And the most DD for this will be lacunar infarct. But we have to remember that the Varsha-Robin space cysts are usually symmetrical. Lacunar infarct is not symmetrical. They are having very regular margin. Infarcts are having irregular margin. And here we can see clustering. Infarct will not be clustered like this. And also hyperintense on T1, T2 because it follows T2 signal intensity. The lacunar infarct, it varies based on the stage of the infarct. So we have to remember that whenever we see multiple cysts which are bilateral symmetrical in the Varsha-Robin spaces, this is Varsha-Robin space cyst or perivascular space cyst. Again, coming to very important cyst, which we diagnose only on basis of location, is the hippocampal sulcal cyst. This is located medial to lateral horn of temporal horn of lateral ventricle. It is seen in the place of hippocampal sulcus remnant. They are again bilaterally symmetrical. Now coming to the intraaxial cyst. Here we can see well-defined intraaxial cyst, which is hypodense on CT. T2 hyperintense, flare may suppress, does not show diffusion restriction, has its own epithelial lining. This is nothing but neuroglial cyst. Most common location is frontal lobe, but in our case, it is in the occipital lobe. So, as I told in the beginning, the most important DD for neuroglial cyst will be porencephalic cyst. And does anyone remember how do we differentiate both? Is correct. Porencephalic cyst will be having communication with the ventricle, whereas neuroglial cyst will be not having any communication. Coming to most important DD for neuroglial cyst, that is our porencephalic cyst. So here we can see a big cystic lesion which is hypodense on CT, T2 hyperintense, flare may suppressed, communicating with our ventricle. This is porencephalic cyst. Even in this image, we can see the big cystic lesion which is communicating with the ventricle. But the important, there will be some history of ischemic insult to the brain, and important DD for this is open lip schizencephaly, which will also be communicating with the ventricle. So, communicates with the ventricle, which will be lined by gliotic white matter. It is lined by adjacent gliotic white matter. There will be history of an ischemic insult, residual cystic lesion. DD for this is open lip schizencephaly, which is lined by the gray matter. So this is open lip schizencephaly. We can see it is communicating the ventricle, but these are lined by dysplastic gray matter. This is again same, summarizing both the difference. Coming to next most common cyst in the intraventricular region, this is in the antenatal scan, we can see choroid plexus cyst. So whenever we see choroid plexus cyst, we have to rule out Edwards syndrome, Achardis syndrome. So in even Achardis disease, there will be corpus callosal dysgenesis. In adult, if when it calcify, we tell it as choroid plex xanthogranuloma. So this is non-neoplastic, most common epithelial line cyst of choroid plexus. There will be usually bilateral located in the atria of lateral ventricle. DD for this is ependymal cyst, which is formed from the ependymal lining. So here again we can see in this image, these are the choroid plexus and there is cyst originating from it. As age increases, it will be calcified. On T2 weighted image, it is hyperintense. T1 hypointense, not suppressed on flare, and twist is it also shows diffusion restriction. Remember, it also shows diffusion restriction. In previously till now we studied only one cyst which shows diffusion restriction, that is yes, epidermoid cyst. So even this also shows diffusion restriction, but it is not true. That is in ADC, it is not hypointense. So this is not true diffusion restriction. Choroid plex involvement, they will usually bilateral, follows the CSF, that is T1 hypo, T2 hyper. Sorry, it doesn't follow CSF. It's T1 hypo, T2 hyper, but it is hyperintense on diffusion weighted image and hypo. Okay, sorry, and on ADC it is not hypointense. This is again, whenever we see diffusion restriction in the choroid plex region, we have to think of xanthogranuloma. Again, we can see a well-defined lesion in the body of the ventricle, and it is having a thin cyst wall. On post-contrast, it is also showing enhancement. This is again the case of choroid plex cyst only. Coming to next most common TD for choroid plexus cyst was ependymal cyst. So here, see, whenever we see the cyst in the choroid plexus, easy way to approach is we have to see where is the choroid plex. If the choroid plex is displaced side, it is ependymal cyst. Ependymal cyst will be originating from ependymal lining. So here we can see there is a well-defined cyst and it is pushing the choroid plex. So this is ependymal cyst. On CT, we can see that the calcified choroid plexus is pushed laterally, means there is a hypodense lesion here, that is ependymal cyst. Here on T2 weighted image, we can see a thin wall of the cyst pushing the choroid plexus. Again, on post contrast image, we can see choroid plexus is pushed sideways, pushed laterally. This is in the position. Here it is pushing the cavum septum pellucidum. So ependymal cyst, cystic lesion in the ventricle, which is thin wall, displaces the choroid plexus away. Again, it's a DD for this is choroid plexus cyst. Now coming to most important spotter. So on we can see a cystic lesion which is hyperdense in CT in the region of foramen of Monro. This is hyper on T1, T2 hypo, not completely suppressed, causing hydrocephalus, transependymal edema. So this is case of colloid cyst. Colloid cyst, we have to always remember three main features for diagnosing. Again, I have asked this in the end. That is, it is location, foramen of Monro. T1, it is hyper. Till now, most of the cysts which we studied, other than white epidermal, was hypo on T1 and neuroenteric also. So this is hyper on T1. T2 hypo does not fully get suppressed by flare. No diffusion restriction. But important thing to remember is it is an emergency because it can cause obstructive hydrocephalus. So always remember, this is the transependymal or interstitial edema caused by the cyst, and usually it indicates that it is acute condition and there can be sudden death of the patient because of this. Just summarizing, the if whenever we see any cyst in the foramen of Monro, it will be most common is colloid cyst. If we are seeing hydrocephalus because of any aqueduct pathology, most common is aqueduct stenosis followed by tectal plate glioma. If it's fourth ventricle, it is most commonly tumor followed by edema or bleed. Now coming to T1 hyperintense lesion, most commonly is if there is mucin. That is in case of Rathke cleft cyst, it is T1 hyperintense. If it's craniopharyngioma, because of presence of keratin, it is T1 hyperintense. Again, because of fat seen in lipoma dermoid, it is T1 hyperintense. And posterior pituitary neurohypophysis is again T1 hyperintense. We have seen many images of ectopic pituitary, ectopic hotspot in case of stalk transition and all. And last is if there is blood or hemorrhage, it is again a T1 hyperintense, which is in pituitary apoplexy because of bleed in the macroadenoma, pituitary macroadenoma. Till now, T1 hyperintense lesion, which we studied, was starting. We have seen white epidermoid, we have seen dermoid, and now we saw colloid cyst, and next we'll be seeing the Rathke cleft cyst. Again, it's based on the location; it is in the cellar region. So here we can see cyst in the cellar region. Here, there is a well-defined cystic lesion which is pushing the adjacent parenchyma. So, it is this is the normal not parenchyma, sorry, adjacent, which is pushing the pituitary to side. So, this is forming a claw. On this is a even post contrast image where we can see the hypointense cyst, but it is pushing the pituitary sidewards, forming the claw. In next image, we can see there is T2 hyperintense cyst, which is having a hypointense nodule pushing the nodule. So these are the two types of Rathke cleft cyst. These are usually asymptomatic. It is formed from the remnant of a Rathke cleft pouch, which forms the anterior pituitary. So it's located between anterior pituitary and posterior pituitary actually. It is asymptomatic, usually detected as incidentaloma, small, intracellular or supracellular, and usually it is non-invasive. Um, and I told calcification, hemorrhage, everything is rare. And there are two variants, that is intracystic nodule, which we saw, and the claw one. Coming to Rathke-Kleffs, this is same which I have summarized. So we have to remember that not everything is T1 hyperintense. Like the one which I showed the example here, the cyst was not T1 hyperintense. So there are two variants. Again, this is very important, and this from this there will be question asked, because only the mucoid variant of Rathke-Kleffs cyst is T1 hyperintense. The serious type is hypo on T1, and T2 it is hyperintense. So we have to remember that the mucoid variant is hyperintense, just like we studied about white epidermoid, which is T1 hyperintense. Now coming to important DD for Rathke-Cleft cyst, which is craniopharyngioma. I told even craniopharyngioma, it is T1 hyperintense, but it is very invasive. It is large, seen in young. 90% of it is calcified based on the variant actually, and it will, but there is a difference in the enhancement. As we saw in this, there was a claw sign. There's only peripheral enhancement of the pituitary which is pushed, but in this case it will show nodular enhancement. One more DD for Rathke-Cleft cyst is pituitary adenoma, cystic variant. Again, the most important differentiating feature will be it is heterogeneous and it will show nodular enhancement. Okay, so that's it. Just now summarizing all the cysts which we studied on based on location. Starting, we studied arachnoid cyst. Most common location is middle cranial fossa. For choroid places, it's lateral ventricle. Colloid cyst, foramen of Monro, causes obstruction. Craniopharyngioma, which is in the suprasellar region. Dermoid, usually midline, T1 hyper. Enlarged perivascular spaces. Epidermoid, most common is CP angle. Ependymal cyst, lateral ventricle, it will push the choroid plexus. Again, in infectious cause, this I have not covered, we'll be studying in next class, that is hydatid. Most common is parietal lobe. We have to remember this. Meningioma in the convexity, neuroenteric cyst we studied, the one which is ovoid shape was T1 hyper, CT hyper, flare height was hyper, it was showing enhancement. So this was in prepontine lesion. Neurocystic sarcosis, again in the convexity or basal subarachnoid space. Neuroglial cyst, most common is frontal lobe, but in our case, we saw in the posterior, occipital lobe. In case of pineal cyst, originating from pineal gland, pituitary adenoma, paracellar region, porencephalic cyst, central hemisphere, Rathke-Cleft cyst with mucus and serous variant in cellar or suprasellar region, schwannoma, CP angle cistern is most common. Okay, now coming to quiz. Yeah, so this is a case of choroid fissure cyst. As I told, spindle shape. The most important is the location, which is a variant of arachnoid cyst only. This is colloid cyst, which is causing the obstruction, hydrocephalus. Is transependymal flow seen more with acute hydrocephalus or chronic? As I told, it can cause sudden death of a patient because whenever we see transependymal flow, it is acute hydrocephalus. This is cribriform state, cribellated, the dilated, enlarged Varsho-Robin space. Questions. How can we differentiate epidermoid, arachnoid, and dermoid cyst? Three features for diagnosing colloid cyst. Okay, so we studied already epidermoid, it will show diffusion restriction. This one will follow CSF, will be having mass effect. Dermoid will be T1 hyper, hypodense on wrist, usually midline lesion, and it will be having other ectodermal origin. It will be having fat, hair, sebaceous cyst, etc. Three features for diagnosing colloid cyst is mostly first is the location, foramen of Monro, causing hydrocephalus, and it will be T1 hyper. Cysts which are showing diffusion restriction, the most was epidermoid, and one more we saw xanthogranuloma, which is not true diffusion restriction. T1 hyperintense cyst, from starting we studied with neuroenteric cyst, white epidermoid, dermoid cyst, then colloid cyst. Then again, what are the variants of Rathke cleft cyst? Serous and mucous variant. Thank you. The reference for today's topic is Osborne and Crack the Code. Coming to spotters. So whenever we see fine reticular pattern, then the most common diagnosis is Barrett's esophagus there because of columnar metaplasia. This is Agnamam spotter. What is the sign? What is this sign called? It looks like something. Yeah, so this is bracket sign which is seen in case of pericallosal lipoma which will undergo calcification. So this is sagittal image of it without calcification. So this is the coronal image of the one other patient which is having calcification. Spotter number 3. So whenever we see the outpoaching or the diverticula in the esophagus, we have to remember that we have upper, mid, and lower. Lower we know epiphrenic. Mid is most common is traction. So this is upper esophagus near the cricopharyngeus. Here we are having only two. Either it should be Kellyan's or Zenker's. So since it is next to vertebral body here, so we know it is posterior. So posterior most common is Zenker's diverticulum. Again, barium swallow image. So here we can see a large filling defect, which is making the obtuse angle. So this is a case of leiomyoma of esophagus, and one more feature will be most of it will be to say that it is leiomyoma is it will be associated with calcification. Last spotter. So in this case, we can see the herniation of the cerebral tonsil when we draw a line from basion to opisthenon more than 5 mm. There is herniation of the cerebral tonsil, and also plus there is syrinx. So this is Arnold Chiari type 1. Just easy way to remember. Easy way to remember Arnold Chiari malformation. So one we already studied, that is there is tonsillar herniation and syrinx. We are having 5. So after one, everything else will be associated with neural tube defect, and we have to start from down. So AC type 2 will be having the myelomeningocele in the lumbosacral region. So there will be cerebellar herniation, everything. Plus additional feature we should see is lumbosacral myelomeningocele. In Arnott Chiari type 3, what will happen is there will be associated cervical encephalocele in the cervical region, cervical or occipital. Then again, we have to go one level up. So in case of 4, there will be cerebellar hypoplasia. Then again, one level up will be AC type 5, in which there will be herniation of occipital lobe. So this is how we can remember all the type 5. That's it. Thank you. Thank you, everyone.